After 60, these medications may affect your intimate health. Before you decide that intimacy changed simply because you turned 60, look at the timing. Did the change begin after a new prescription? After a dose was increased? After a second medicine was added? Or after an over-the-counter PM product quietly became part of your nightly routine? A medicine can protect your heart, calm anxiety, reduce pain, improve urination, or help control cancer and still affect desire, arousal, erections, ejaculation, orgasm, or physical comfort. That doesn't make the medicine bad, and it does not mean the medicine is definitely the cause. But it does mean the change deserves a proper medication review instead of silence, embarrassment, or self-blame. In this video, we will examine 7 medication groups that may affect intimate health after 60. We will also uncover the timing clue that makes a medication connection more likely, the hidden products people often forget to mention to their doctor, and the dangerous self-treatment mistake that can cause blood pressure to fall to an unsafe level. One safety rule applies to everything you are about to hear. Never stop, skip, or change a prescribed medicine on your own. Some of these treatments prevent strokes, control serious mental health conditions, manage severe pain, or slow hormone-sensitive cancers. The safe goal is not to abandon treatment. It is to identify a possible side effect and ask whether the treatment plan can be reviewed. Now imagine a 68-year-old man named Robert. His blood pressure is finally under control. His doctor is pleased. His numbers look better than they have in years. But at home, something else has changed. An erection that used to be dependable is no longer predictable. Robert says nothing because he assumes it is age. Then he begins avoiding affection because he is afraid one intimate moment will confirm his worst fear. The clue is not that Robert takes a blood pressure medicine. Millions of people take these medicines without the same problem. The clue is that the change began several weeks after his treatment was adjusted. Some blood pressure medicines, including certain diuretics, often called water pills, and some beta blockers, are associated with sexual side effects in some people. Depending on the medicine and the person, that may include erectile difficulty, lower desire, or fatigue that reduces interest and responsiveness. But this is where the story becomes more complicated. High blood pressure itself can damage blood vessels and contribute to erectile dysfunction. Diabetes, heart and blood vessel disease, smoking, depression, poor sleep, and other health conditions may also be involved. So Robert cannot prove that one tablet caused the problem simply because the dates seem connected. What he can do is bring the timeline to his clinician. He can say, "My blood pressure has improved, but my erections changed after the dose was increased." Could the medicine be contributing, and should we check for other causes? That is a much safer question than quietly missing doses. A clinician may review his cardiovascular risk, check other possible causes, examine interactions, and decide whether the current medicine remains the best choice. The most important change for Robert is not instant performance. It is the realization that this symptom is information, not a verdict on his age or masculinity. But what happens when blood flow is not the main clue? What if a person still loves their partner, still wants closeness, and yet the internal signal of desire suddenly feels muted? That is where antidepressants enter the picture. Imagine a woman named Margaret who begins treatment for depression after a difficult year. Within a few months, she is sleeping better. She is less overwhelmed. She begins enjoying ordinary parts of life again. But she notices a change she did not expect. Touch still feels affectionate, yet desire is weaker. Arousal takes longer. Reaching orgasm has become difficult, and sometimes it does not happen at all. Her partner quietly wonders whether the relationship has changed. Margaret quietly wonders whether she has lost an essential part of herself. Certain antidepressants, particularly selective serotonin reuptake inhibitors or SSRIs, can cause sexual side effects. Official drug labeling for medicines in this group describes decreased libido, delayed or absent orgasm in women, and delayed or failed ejaculation, decreased libido, or erectile dysfunction in men. The underlying depression or anxiety can also affect sexual function. That is why timing and detail matter. Did the problem exist before treatment? Did it improve as the mood improved? Or did it first appear after the medicine began or the dose changed? Margaret's most useful sentence is not, "This medicine ruined my intimate life." It is, "My mood is better, but my sexual response changed after treatment began." That tells the prescriber two important truths at once. The medicine may be helping, and the side effect may still deserve attention. A prescriber may consider the exact medicine, the dose, other drugs, other medical conditions, and the risk of changing a treatment that is improving mental health. Margaret should not suddenly discontinue an antidepressant. The decision needs to be planned with the prescriber, and she should not assume reduced response means reduced love. Sometimes the relationship is being blamed for a change that began in the nervous system. The next group can create a different kind of fear because the change may happen at the moment of ejaculation. Without an explanation, some men believe something has been damaged. Medicines used for an enlarged prostate do not all work in the same way, and they do not all produce the same effects. Tamsulosin is an alpha blocker used to relax muscles in the prostate and bladder area so urine can flow more easily. Its official labeling describes abnormal ejaculation, including ejaculation failure, reduced ejaculation, and retrograde ejaculation. In retrograde ejaculation, semen moves backward into the bladder instead of leaving the body in the usual way. For some men, the first sign is that orgasm feels different or little fluid appears. That can be startling. But a medication-related ejaculation change is not the same as suddenly becoming incapable of intimacy. Another group of prostate medicines includes finasteride and dutasteride. These medicines affect the hormonal pathway involved in prostate growth. Known sexual side effects can include decreased desire, erectile difficulty, and reduced ejaculate volume. Notice the distinction. One prostate medicine may be more closely associated with a change in ejaculation. Another may affect desire, erection, or semen volume through a different mechanism. That is why saying, "I take a prostate pill," is not enough during a medication review. The exact name matters. The exact symptom matters too. Is the problem lower desire, difficulty getting an erection, a change in ejaculation, pain, or anxiety after seeing less fluid? Those details help the clinician separate a known medication effect from a symptom that needs another explanation. And if fertility matters, that needs to be said clearly as well. Now we move to a problem that can develop so slowly that the medicine becomes almost invisible. It may not begin a few days after the first dose. It may appear after months of chronic pain, poor sleep, reduced activity, and long-term treatment. Opioid pain medicines can be necessary when pain is severe and other treatments are not enough. But official opioid labeling warns that chronic use may affect the hormone signaling pathway between the brain and the reproductive system. This may be associated with androgen deficiency and symptoms such as low libido, impotence, erectile dysfunction, absent menstrual periods, or infertility. The labeling also makes an important point. The causal role is not always clear because chronic pain, physical illness, stress, sleep problems, mood, and lifestyle can also influence hormone levels and sexual function. In other words, the medicine may be part of the picture without being the entire picture. A person may describe the change as a slow dimming. Less energy, less interest, less confidence, fewer spontaneous, intimate thoughts. An erection that is harder to maintain, or a sense that the body has stopped responding with the same intensity. Because the medicine has been taken for a long time, nobody connects it to the symptom. This is where a focused review can be valuable. The clinician may consider the dose, duration, other sedating medicines, the overall pain plan, and whether symptoms suggest that laboratory evaluation is appropriate. But an opioid should not be reduced or stopped without medical supervision. Withdrawal, uncontrolled pain, and destabilization of the treatment plan can create serious problems. The goal is not to trade pain control for intimate health. The goal is to make sure both are part of the same conversation. Now check the bathroom shelf, the kitchen drawer, and the bedside table. The next medication may never appear on the prescription list because the person does not think of it as a medicine. It may say nighttime. It may say PM. It may be marketed for allergies, colds, or sleep. Some older antihistamines, including diphenhydramine and doxylamine, can cause drowsiness and dryness. The National Institute on Aging also lists antihistamines among medicines that can interfere with sexual function in some older adults. Medline Plus notes that older adults generally should not use diphenhydramine or doxylamine routinely because they may be less safe or effective than other options for many uses. That does not mean one occasional dose explains every intimate symptom. It means frequent use deserves to be visible during a medication review. Imagine Helen, who says she takes only 3 prescriptions. When the pharmacist asks about over-the-counter products, she remembers a nighttime tablet she has used for months. She never counted it because she bought it without a prescription. Yet the same period included more daytime grogginess, less energy, greater dryness, and less interest in closeness. Her symptoms may still have several causes. Menopause-related tissue changes, sleep disruption, other medicines, stress, and health conditions may all contribute. But the nighttime product belongs on the list. Combination products are especially easy to miss. A pain reliever or cold product with PM on the label may contain a sedating antihistamine. So when a doctor or pharmacist asks what you take, include the bottles from the store, not only the bottles from the pharmacy. The next category is more sensitive because the medicine may be protecting a person from severe psychiatric symptoms, yet it can also affect a hormone many patients have never heard of. Certain antipsychotic medicines can influence prolactin, a hormone produced by the pituitary gland. Risperidone is a well-documented example. Its official labeling states that it raises prolactin and that sustained elevation may interfere with reproductive hormone function. Reported effects connected with prolactin-elevating medicines include impotence, menstrual changes, breast enlargement, and unexpected milk production. Decreased libido and difficulty reaching orgasm have also been reported with risperidone. For the person experiencing this, the symptom may feel deeply confusing. A man may notice reduced desire and erectile problems. A woman may notice sexual changes, menstrual changes, or breast symptoms. Neither may realize that a blood test and medication review could be relevant. But this is not a medicine to stop secretly. Antipsychotic treatment may be preventing hallucinations, severe mood episodes, relapse, or hospitalization. A sudden change can place the person at serious risk. The right conversation is direct and respectful. My mental health symptoms are more stable, but I have noticed these physical changes. Could prolactin or another medication effect be involved? That allows the prescriber to evaluate the symptom without treating intimate health as unimportant. Stability matters, safety matters, and quality of life matters too. The final medication group creates the hardest emotional conflict of all. The treatment may be helping control cancer while changing desire, erections, vaginal comfort, energy, or the way a person experiences their own body. Hormone therapy is used because hormones can help certain cancers grow. For prostate cancer, androgen deprivation therapy reduces or blocks the action of male hormones. The National Cancer Institute lists lowered libido and sexual difficulties among its possible effects. For hormone-sensitive breast cancer, endocrine treatments may block estrogen effects or reduce estrogen production. Possible effects can include loss of interest in sex, vaginal dryness, hot flashes, and discomfort during intercourse. These are not minor concerns simply because the treatment is important. A person can be grateful for cancer treatment and still grieve a change in intimate life. A partner can be supportive and still feel uncertain about how to begin a conversation. A survivor can want the strongest cancer care available and also want help with comfort, desire, body image, or sexual function. Those needs do not compete with survival. They are part of survivorship. But hormone-sensitive cancer also makes self-treatment especially risky. A product that seems harmless or natural may not be appropriate for every cancer history. A local or systemic hormone treatment that is reasonable for one person may require a different decision for another. The oncology team needs to be involved. Ask what non-hormonal options are available. Ask whether a symptom should be evaluated by a specialist. Ask what treatments are compatible with the specific cancer, medication, and medical history. Do not let embarrassment push the problem outside the cancer care conversation. Now we reach the question that matters most. How do you tell whether a medication may be involved without guessing? Use a 4-part medication timeline. First, write down when the intimate change began. Use the closest date or life event you can remember. Was it before or after a new medicine? Before or after a dose increase? Before or after surgery, cancer treatment, a major illness, worsening pain, depression, or a relationship change? Second, describe the exact symptom. Do not write only, intimacy is worse. Write what changed. Desire became lower. Arousal takes longer. An erection is less firm or does not last. Ejaculation changed. Orgasm is delayed or absent. Dryness or pain appeared. Fatigue or dizziness makes closeness difficult. These symptoms point toward different possible causes. Third, list everything you use. Include prescriptions, injections, creams, patches, inhalers, occasional medicines, allergy tablets, sleep products, pain relievers, vitamins, and supplements. Include the dose if you know it and the time of day you take it. If the list is difficult to build, place the actual containers in a bag and bring them to a pharmacist or appointment. Fourth, ask 4 direct questions. Could any of my medicines contribute to this change? Could 2 or more medicines be interacting? Could the health condition itself be causing the symptom? And is there a safer way to manage the side effect without losing the benefit of treatment? Those questions do not accuse the medicine. They open an investigation. And that investigation matters because an intimate change can sometimes reveal more than a side effect. Erectile dysfunction may be associated with diabetes, high blood pressure, heart and blood vessel disease, neurological conditions, mental health factors, or medications. Pain during intimacy may be related to menopause-associated tissue changes, infection, pelvic floor problems, skin conditions, cancer treatment, or other causes. A sudden or severe change should not be dismissed as normal aging. Now for the self-treatment mistake mentioned at the beginning. Some people are too embarrassed to discuss the problem, so they order a sexual enhancement product online, buy a honey or capsule advertised as all natural, or use someone else's prescription. The United States Food and Drug Administration has repeatedly found hidden prescription drug ingredients in products marketed for sexual enhancement. Recent FDA alerts have included products containing undeclared sildenafil or related ingredients. That creates a serious danger because sildenafil, tadalafil, and similar erectile dysfunction medicines can interact with nitrate medicines used for chest pain, such as nitroglycerin, and lower blood pressure to dangerous levels. The product label may not warn you if the ingredient is hidden. Natural on the package does not prove the product is safe, and a medicine that was prescribed to another person was not evaluated against your heart condition, blood pressure, kidney function, or medication list. There is another urgent warning worth remembering. An erection that lasts longer than 4 hours requires immediate medical care. Do not wait for it to resolve on its own. The safest path is not secrecy, borrowed medicine, or an unverified supplement. It is a medical review that considers the symptom, the condition being treated, every medicine being taken, and the person's cardiovascular and overall health. After 60, intimate changes are common, but common does not mean meaningless. The problem may involve aging. It may involve blood vessels, hormones, nerves, mood, pain, sleep, cancer treatment, the relationship, or several factors at once. And yes, sometimes the medicine cabinet contains an important clue. Do not stop a treatment that protects your health. Do not assume a side effect is permanent. Do not assume your partner caused a change that began after a prescription was adjusted, and do not assume your clinician will ask first. Bring the timeline. Bring the bottles. Name the exact symptom. Ask the uncomfortable question. Because the conversation you are avoiding may protect both your health and a part of your life you thought you had lost. But there is one more issue every older adult should understand before using an erectile dysfunction medicine. It is not simply whether the medicine works. It is whether the heart and the rest of the medication list make intimate activity and treatment safe in the first place. In the next video, we will examine the warning signs during intimacy after 60 that should never be ignored, including the symptoms that mean it is time to stop and seek urgent medical help.